Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds, and welcome back to the CardioNerds Cardio-Oncology series. This is Diane Ambinder, and I am so excited to be here today. We're going to be discussing the crucial role of cardiac imaging with regards to cardio-oncology. Joining us for this exciting discussion, we have one of the series co-chairs, Dr. Giselle Suero Abreu, who is a cardiology fellow and cardiac imaging fellow at MGH, as well as part of the CardioNerds Ambassador Program. So, Giselle, welcome. Why don't you take things forward?
Thank you so much for the introduction, Dan. Today, we have Dr. Iva Minga, who is an advanced cardiac imaging fellow from the University of Chicago and is joining us as the fit lead for this exciting episode. It is so great to finally meet you, Iva, given our shared interest in cardio-oncology and cardiac imaging. Iva has actively worked in many clinical and research projects in cardio-oncology, including the first patient education cardio-oncology series in Illinois, and is the fellow representative at the interdisciplinary Chicago-wide cardio-oncology rounds. Welcome to the cardio-oncology series, Iva.
Thanks, Giselle. Today, I have the great privilege of introducing Dr. Nausheen Akhter. Dr. Akhter is the Director of Cardio-Oncology at Northwestern Medical Center in Chicago. She completed her medical school at Northwestern, residency at Indiana University, and fellowship at University of Illinois College of Medicine in Chicago. I have had the pleasure of working with Dr. Akhter on several occasions, including in the echo reading rooms, performing TEs, clinics, and research projects. She's incredibly committed to the education of her fellows and is always supportive. It has been an absolute pleasure and privilege to work with her.
Dan, Giselle, and Iva, it is a great honor to be here with you today. Congratulations to everyone involved in this phenomenal cardio-oncology series on cardio-oncology. I am a big fan, and I'm very excited to discuss our topic today on cardio-oncology and imaging, which sounds like is a shared passion with both of you.
Absolutely. We're going to have a great episode, and we're ready to illustrate the importance of imaging in cardio-oncology through some cases from our CardioNerds clinic. So for our first patient, we have a 32-year-old female who has a BRCA1 mutation and unfortunately has been diagnosed with triple-negative breast cancer. As part of her treatment, she'll undergo anthracycline therapy and radiation. Dr. Akhter, would you be able to guide us on how would you manage this patient prior to initiating medical therapy? And specifically, does she warrant any baseline imaging?
This is a young patient with an aggressive cancer diagnosis who requires cardiotoxic therapy. So we really want the best possible outcome for her. As part of her team, our goal in cardio-oncology is to partner with her and with her oncology team to help her receive treatment with minimal adverse cardiovascular effects. Oncology has been using anthracyclines for several decades, and we know a great deal about the adverse effects of these drugs. They've been around since the 1970s. Primarily, there is a dose-dependent cardiovascular toxicity. A high dose of anthracycline is considered 250 milligrams per meter squared of a doxorubicin equivalent. And for our breast cancer patient, she will likely receive a regimen that will total 240 milligrams per meter squared of doxorubicin. This is a moderately high dose. Secondly, it's important to remember that adverse cardiovascular effects can occur both within the first year of treatment and also years later. So anthracyclines are known to double the risk of heart failure in 10 years. Additionally, in the breast cancer population, there's other agents that are given concomitantly that have cardiotoxic effects, such as anti-HER2 therapies, left-sided radiation, and now even immunotherapies, which are being given to triple-negative breast cancer patients. So there's a lot to consider, not just now, but potentially in the future for her. Therefore, every patient who receives anthracyclines or any cancer therapy that can cause what we call cancer therapy-related cardiac dysfunction, and I know that this has been covered in a previous CardioNerds podcast, is required to have a baseline echocardiogram to assess for structural heart disease and to also serve as a comparison to follow serially during and after therapy. LVEF is the traditional measure of cardiac function, and it can be measured both in 2D and 3D echocardiography. However, 3D echo is preferred when possible or where possible, as there is thought to be less temporal variability between studies with 3D echo. Global longitudinal strain is also considered an imaging biomarker with a prognostic role in cardio-oncology. It is more sensitive and reproducible measure of cardiac function. It's also been studied extensively in HER2-positive breast cancer patients and in patients with hematologic malignancies undergoing anthracycline chemotherapy. One of my colleagues, Dr. Scherer Crosby, who is at the University of Pennsylvania, has demonstrated that the pre-chemotherapy baseline global longitudinal strain in patients treated with anthracyclines can actually predict cardiac events. And then with that information, went on to create a 21-point risk score, which included this baseline global longitudinal strain to predict heart failure events in patients with leukemia who are receiving anthracyclines. At Northwestern, we've actually validated that risk score. So if our patient is found to have a baseline reduced EF prior to starting anthracycline therapy, we would start her on goal-directed medical therapy and follow her very closely in our clinic during treatment with imaging surveillance at least every other cycle. Can that same protocol be used for a baseline reduced global longitudinal strain to stratify patients for prophylactic therapy and closer surveillance? Well, we don't have the answer to that, and that does require further study.
What a great overview, Dr. Akhter. And as you mentioned, to all cardio nerds looking for a more in depth discussion of cancer therapy related cardiac dysfunction, from the perspective of an oncologist, you can hear from Dr. Susan Dent on episode 261. And from the perspective of a cardiologist, you can hear from Dr. Jor Hermian in episode 274. Dr. Akhter, what would be your approach if the echocardiogram does not provide reliable measurements of cardiac function to get that baseline that you were mentioning? And is that the moment that you would consider an advanced imaging, such as MRI? Or even is there a role for evaluating the EF with the long-standing MUGA scan?
So, echo is well tolerated by patients. It's available, it's portable, it's affordable, but echo can be technically limited, and especially in our breast cancer population. And so I think the first step, if we do have an issue with technical challenges, is to give contrast enhancement. 3D echo, although we just discussed that it is the preferred way to surveillance patients because of the reduced temporal variability between studies, it's also dependent on the 2D image. So, your 3D echo will only be as good as your 2D images. 3D echo with contrast has also been looked at, and 3D echo with contrast is not superior to just 3D echo with regards to detection of cardiotoxicity. And so, the first step would be to try the contrast enhancement. But if we still are not able to get an accurate ejection fraction, yes, that is when we could start to think about other advanced imaging modalities such as MRI. And MRI is considered a gold standard for assessment of cardiac structure and function. It is not only an accurate assessment of ejection fraction, but can also help us with etiologies of the cardiomyopathy and pericardial disease. The limitations of the MRI, however, are that is not readily available at all hospitals and most places. It's more expensive. And patients with claustrophobia cannot tolerate an MRI. Also, early formulations of gadolinium, which were associated with nephrogenic systemic fibrosis in patients with renal dysfunction. However, this is now more rare with newer gadolinium formulations. You mentioned MUGA, and MUGA is sort of a third line assessment for LV ejection fraction. It is highly reproducible, however, does not provide other details and information about cardiac structure, and has also fallen out of favor due to repeated exposure to radiation for the patient. A specific patient population which MUGA is still useful are breast cancer patients with tissue expanders who have poor echo windows. And these patients can also not get a cardiac MRI due to their expanders with associated magnetic ports, which are not MRI safe. And so, all of these things have to be considered when we're deciding on, the best way to surveillance our patients. And all of these modalities still have their place, but echo is our central cornerstone surveillance modality.
This has been a great overview of the main imaging modalities relevant to cardio-oncology patients. The 2022 European Society of Cardiology Cardio-Oncology guidelines offer a detailed step-by-step approach to what to do at different stages of treatment and monitoring, and is an excellent choice to guide us through the decision-making process. Dr. Akhter, now that the patient has started treatment, how would you monitor a patient like this with imaging in your cardio-oncology clinic?
We have already discussed that this patient is receiving a moderate dose of anthracycline therapy and radiation. It wasn't included if this was a left-sided radiation, but left-sided radiation would place the patient at even higher risk for development of cancer therapy-related cardiac dysfunction. And so she is someone I would consider at high risk for cardiotoxicity. So she should receive an echo with 3D and global longitudinal strain at the completion of her anthracycline treatment. And based on the ESC Cardio-Oncology guidelines, if she is asymptomatic, she would receive another echo at the 12-month point post-treatment. Now, this surveillance will vary if she has a reduction in her EF at baseline, as we have discussed, or if she develops CTRCD. The surveillance may be more frequent. The definition for CTRCD is also now more nuanced and evolving. So traditional definitions have utilized primarily ejection fraction, and one that's very easy to remember is a greater than 10% decline from the baseline ejection fraction, but also has to kind of hit a threshold or nadir value to lower limits of normal. Between cardiology and oncology societies, that can range between 50 to 53%. But newer definitions that are being incorporated in the ESC Cardio-Oncology guidelines include both LVEF and global longitudinal strain and or biomarkers. So it is important to consider now the severity of CTRCD by symptoms and by ejection fraction, broadly corresponding to sort of preserved mid-range and reduced ejection fraction.
So, specifically for our patient, let's say she develops cardiotoxicity and her EF drops from like 60% to 45%, and she's still undergoing her treatment. Would you recommend discontinuation of treatment? Or can you discuss with her team an approach for permissive cardiotoxicity? And is there any role of initiating therapeutic intervention to guide the patient through this treatment, such as GDMT for heart failure?
Yes, all really important considerations. Giselle, if the patient is asymptomatic, I would have a discussion with her oncology team about the safety of continuing therapy in her, especially if this treatment is needed for curative intent and there are no other options for her. I would advocate for continuing therapy, and I would advocate for the addition of goal directed medical therapy while she continues therapy. There are really kind of two primary reasons in where we would consider discontinuation of therapy. One is if she has developed symptomatic heart failure. So she's in clinically volume overloaded, short of breath, requiring diuresis. And then the second is if the ejection fraction is severely reduced, so drops to less than 40% per the guidelines. So there is a role for permissive cardiotoxicity in the asymptomatic patient. And there were two small studies that have looked at HER2 positive breast cancer patients. Specifically, they were the Safe Heart and the Scholar studies. And they evaluated the safety of continuing therapy in these patients. All of the patients included in those small trials had an ejection fraction greater than 40% and were asymptomatic. And all of the patients had regular cardio-oncology follow-up visits, serial echoes, and were on goal-directed medical therapy. There is a growing role for permissive cardiotoxicity. And I think that as a community, as our experience grows with these high risk patients, we are becoming more brave in allowing necessary cardiotoxic treatment with very close monitoring of our patients.
Thank you so much for that, Dr. Akhter. It really does make sense. This is really an excellent discussion on the utilization of imaging in surveillance of cardiotoxicities during cancer treatment. And for those of you who are interested, which should be everybody, check out our episode on advanced heart failure in cardio-oncology to learn more about treatment aspects and considerations and when we push the limits further. Dr. Akhter, what about the long-term surveillance after cancer therapy? What would be your strategy for monitoring cardiac function? And is there a point in time in the future where you're like, this patient has been doing so well for so long, I can pretty much stop surveillance and kind of bring them back to the general population? What are your thoughts on that?
So I get asked this question by the patient's primary providers. And also, kind of a second part to this question is, from patients too, like if they're on GDMT, well, he can stop that. But to specifically answer this question, with regards to long term surveillance in adult cancer survivors, for a very long time, this was just a big black box. Like we didn't have any real guidance in this space. However, the ESC cardio-oncology guideline statement has now provided some more guidance in this regard in our asymptomatic cancer survivors who are at moderate and high risk for cardiotoxicity. These patients should be receiving an echo at the 1 year post treatment time point. And then periodically thereafter, they suggest at 1, 3, 5 years. And if the ejection fractions remains in a normal range and the patient is still asymptomatic, then maybe every 5 years. Obviously, this surveillance period would change if the patient becomes symptomatic or if there is a drop in the ejection fraction at any one of those intervals. Regarding stopping surveillance, with regards to anthracyclines specifically, I would not. I would continue periodic long term surveillance for patients over their lifetime because we do know that patients can have long term adverse effects. The answer to this question may differ based on the cancer therapy type, but specifically for anthracyclines, would continue long term periodic surveillance.
What a fantastic discussion with excellent teaching points. Let's move on to case 2. For our case 2, we have a 25-year-old male who presents to established care. He has a history of non-Hodgkin lymphoma at the age of 7 and received radiation to the chest. How do you perform surveillance on this patient and what should be on the lookout for?
Yeah, so at our institution, and probably at many institutions, we have a childhood cancer survivorship clinic, and they follow the Children's Oncology Group guideline regarding surveillance of childhood cancer survivors. Surveillance recommendations are based again on anthracycline and radiation doses. So for high dose anthracycline, which is again greater than 250 milligrams per meter squared of a doxorubicin equivalent, and any or no radiation, the echo surveillance according to the COG guidelines is every 2 years. Younger age of exposure is a risk factor for radiation associated cardiovascular effects, which can have an effect on really any structure in the radiation field. So if we go kind of from the external part of the heart to more internal, that includes the pericardium, the coronary arteries, the myocardium, and then heart valves, anterior valve structures like the aortic valve and the anterior mitral valve leaflet are more affected than anything else in terms of the great vessels, aorta, carotid arteries, and then pulmonary fibrosis. So there tends to be a shorter latency for the development of adverse effects such as coronary artery disease. We see that about 10 years after exposure, and a longer latency for valvular heart disease, which is usually many decades later. Multimodality imaging, such as echo, CT, MRI, all have their role to assess for various specific complications. We are also now more commonly looking at CT TAVR when planning for surgical or transcatheter aortic valve replacement in patients with radiation valve disease too.
Imaging in cardio-oncology really complements a lot of the information that we learned in our series so far. So, to learn more about radiation associated cardiovascular disease, I would recommend to go listen to episode 238 with Dr. Eric Yan, where we learn a lot of the details on this particular aspect of cardio-oncology that now we had such a great perspective from the imaging side as well. I'm going to take a minute to take us back to our patient. So let's say he continued to follow up in your clinic and at age 35 developed iron deficiency anemia and was found to have colon cancer, unfortunately. He will undergo surgical resection and then chemotherapy, but has also been complaining recently of chest pain during exertion. The general team would like to do a preoperative risk stratification for him. And we were wondering, how will you use imaging to help with this risk stratification and evaluate further this patient's chest pain, since actually his team is planning to include 5FU as part of his chemotherapy. What are your thoughts there?
Yeah. So I think that you would risk stratify this patient as you would any patient who is undergoing like a surgical evaluation with chest pain, exertional chest pain. So you do an ischemic evaluation. And with regards to 5FU, it can also very commonly cause chest pain. And the mechanism is primarily thought to be due to vasospasm. So this ischemic evaluations are double for risk stratification for his chemotherapy as well. We know from a study by Dr. Zuffer and colleagues is that 5FU associated vasospasm was more often found in younger patients with fewer cardiovascular risk factors. And so a nice role for risk stratification would be to use a coronary CT angiogram. This really is a perfect tool to evaluate chest pain in patients without any significant risk factors. And especially for patients who are on 5FU with chest pain, and we think it's due to vasospasm, because the coronary CT scans have a high negative predictive value. They can easily exclude coronary disease. In our patient who has anemia, also likely related to a GI bleed due to the colon cancer, this is another reason to pursue a non-invasive evaluation for his chest pain.
That was an excellent discussion. Chest pain due to 5FU associated vasospasm is an important entity to recognize in clinical practice. And definitely imaging plays a key role in distinguishing it between ischemic chest pain versus vasospasm. Now we are ready to move on to our next case. We have a 70-year-old African-American male with a family history of heart failure that presents with bilateral carpal tunnel syndrome and back pain. Due to the family history, the primary care physician obtained an echocardiogram, and it showed that he had ventricular hypertrophy with an intraventricular septum measuring at 1.7 centimeters. He also has a history of multiple myeloma that was treated 10 years ago, and it's currently in remission. He presents to your clinic for further evaluation. Dr. Akhter, what would be your next steps for a patient like him?
So any patient with a history of multiple myeloma with left ventricular hypertrophy who is suspected to have cardiac amyloidosis should have an evaluation with an echo with strain. There is a classic strain pattern associated with cardiac amyloidosis on the bullseye plot, which is that polar map that you get at the end of doing strain that demonstrates an apical preservation and reduction of global longitudinal strain in the basal and mid segments. So it looks like an ice cream with a cherry on top. Cardiac MRI can also be a sensitive, non-invasive tool to better evaluate the tissue characterization for patients with suspected cardiac amyloidosis. The main cardiac MRI finding of amyloidosis is a diffuse subendocardial or transmural late gadolinium enhancement, but the extracellular volume is an even more suggestive and prognostic marker, especially if that extracellular volume is greater than 40. So if it's very high, that really increases our specificity for the diagnosis of cardiac amyloidosis. The issue with MRI, however, is that it cannot distinguish amyloid types. So although we can suspect cardiac amyloidosis, we would have to do further genetic testing. Another type of imaging modality, the PYP scan, however, is more specific for TTR amyloidosis. But even with PYP scans, about 10% of positive PYP scans are AL amyloidosis. We have all of these imaging tools in our armamentarium for studying patients with left ventricular hypertrophy who we suspect have amyloidosis.
Clearly, this episode illustrates how much imaging is related to many things cardio-oncology. Finally, we also must mention the crucial role of imaging in patients undergoing treatment with immune checkpoint inhibitors. We have a very interesting episode in this cardio-oncology series that discusses the topic of immune checkpoint inhibitors in cardio-oncology, led by Dr. Thomas Nealon. At this moment, can you share with us briefly about the utility of imaging in patients receiving immunocheckpoint inhibitors that could be developing side effects such as myocarditis or atherosclerosis?
Oh, thank you, Giselle, for that question. This is another utility for echo with global longitudinal strain in patients who are on immunotherapy and are clinically suspected to have immune checkpoint inhibitor myocarditis. Global longitudinal strain and global circumferential strain have been looked at in this population. And a global longitudinal strain was predictive of MACE in patients with ejection fractions greater than 50% and with a reduced GLS. It's an additional parameter that we can use on echo to help us sort out if this patient has myocarditis. As per Dr. Nealon's episode, that patients with ICI myocarditis, greater than 50% of those patients have preserved ejection fraction. And so that's where global longitudinal strain really is powerful and useful. Cardiac MRI also has an essential role in the non-invasive assessment of ICI myocarditis, and it is in fact considered a major criteria in the diagnosis of acute myocarditis in patients on immune checkpoint inhibitors. As you mentioned, there's also this growing recognition of ICI-associated atherosclerosis. The role of imaging here, particularly coronary calcium score and coronary CT angiograms in risk stratification, surveillance, and management, has yet to be explored.
Dr. Akhter, cardio-oncology in the field of cardiology is rapidly growing with new development of cancer treatment drugs, and it seems like that's happening almost every day. There's so much excitement about the many aspects of this emerging field. So, for you, what makes your heart flutter about cardio-oncology?
So I love this question, and I'm going to answer it in two parts. One, yes, I completely agree. There's so much that is exciting in this field. And I am humbled on a daily basis to learn about new drugs, mechanisms, their effects. But what makes my heart flutter is the utility of imaging in cardio-oncology. I guess that's why I'm the expert for this episode, not just for the diagnostic purpose, but for the prognostic purpose. Global longitudinal strain and other advanced imaging parameters on cardiac MRI, these are all very powerful tools. And I see them as having the ability to look into a crystal ball and see the future for patients on these treatments and that can predict adverse outcomes. Advanced imaging protocols with strain in cardio-oncology have really led cardiology in the development of surveillance algorithms for heart failure. And this has been very exciting. What also makes my heart flutter are people like you in our field. There are so many exciting opportunities for the curious, non-invasive, and invasive cardiologists. This is a really important area of focus for the next generation of cardio-oncologists like yourselves to think about designing and leading randomized clinical trials. And so I'm looking forward to all that you and your colleagues will contribute to this field.
Thank you so much, Dr. Akhter, Eva, Dan, for joining this amazing discussion about a topic that certainly makes everyone's in this call heart flutter, which is cardiac imaging in cardio-oncology. Thank you to all the cardio nerds listening today, and do not miss the rest of the episodes in this very exciting series.
Thank you so much for tuning in to this Cardio Nerds episode. The audio editing for this episode was performed by me, Diane Masket. I'm an intern in the CardioNerds Academy House Thomas and fourth-year medical student at Rowan Virtua School of Osteopathic Medicine in New Jersey. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to Cardio Nerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All Cardio Nerds content is planned, produced, and reviewed solely by Cardio Nerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.